what's called a release of a tendon. There's a very common phenomenon mentioned earlier called a snapping hip. A lot of young girls tend to get this more than anybody else. So they're walking and just pop, pop, pop. It just keeps snapping. And there are different causes for it, but generally it's a tendon that's very tight in the hip area. And thankfully, arthroscopically, we can go in and fix the problem by just cutting the tendon a little bit. Thankfully, most of these patients do get better with physical therapy. And then there are other tendons around the hip, what we call the gluteal muscles. These are the abductors, the muscles that help us raise the leg to the side. And so sometimes those tendons can be torn, but thankfully can be fixed arthroscopically. Post-operatively, all these patients, we put them on a stationary bicycle. If not the day of surgery, the day after surgery. You'll get sent to your home a bending machine. The idea is to start moving the hip as quickly as possible. Generally, you'll have to use crutches for about 2 to 4 weeks. Generally, we'll get patients back in the gym at about 4 weeks, back to sports at about 3 to 5 months. And when we say 3 to 5 months, meaning that you could actually cut and pivot pretty comfortably. This is just some video demonstrating what it actually looks like inside the hip joint. So on the left is what we call the labrum. To the right is the ball, or what we call the femoral head. So this is an opportunity to see exactly what we see during surgery. So there are certain things we do to get in there and try to give us a better visualization. And so in this particular patient, this patient had extra bone on the socket side, so we're in there trying to clean up some of the soft tissue so we can see the extra bone, so we know exactly where we have to reshape. Hope nobody gets freaked out by this. And then once we have that all separated out, then we can go in, clean up all the soft tissue, clean up the cartilage. We have a little machine that basically reshapes the bone. It's like an ice sculpture. We're basically going in and resculpting the bone, making it look more normal. And then the way we fix it, this is what we use. We use what are called anchors. We pass some stitches around the bone, stitches around the labrum or around the tissue that we're going to fix. And then we're able to, you actually have to drill a hole. You have to drill a hole in the bone, and that makes the place where you're going to place the anchor. These anchors, they're usually generally very white. They're very small. They're about the size of the tip of a pen. Usually we'll use 1 or 2 in the hip in particular. And that's what it looks like. And that's a repair. And then the other videos just showed reshaping of the bone for the impingement. So in conclusion, hip pathology you have to think patients who are very active. People used to just blow it off and say, oh, it's just a groin pull. It's just a groin pull. And then patients or athletes keep having the same problem for years, and they never realize it's actually something a little more serious. This is a very, very successful procedure for athletes in case they do have a particular problem that needs arthroscopic surgery. It's not a replacement it's not a substitute for hip replacement. This is not a treatment for hip arthritis. All these patients, anybody with hip pain should start with physical therapy or anti-inflammatory medicines. And certainly if that doesn't help, then at that point you should probably refer to an orthopedic surgeon. Thank you.
So I'm going to take a moment to introduce our first athlete. Just going to say a couple words. It's actually really special for us because Ortho Now wants to be very involved in the community. And a couple years ago, when the hospital systems wasn't able to continue doing their physicals, we really stepped up, and we do these free of charge, of course. But it basically allows the Special Olympics athletes to compete, which is a requirement for them. And actually, one of the most renowned Special Olympians in the world actually is here in Miami. He's set all kinds of records in swimming, particularly open water distance swimming. So I'd like to introduce Andy Miyares.
Good evening, ladies and gentlemen. It's an honor to be here today. Let me introduce myself. Andy is my name. Swimming is my game, and Special Olympics is my life. I have been a Special Olympics athlete since I was 8 years old. I have participated in bowling, basketball, tennis, and track and field, but swimming is my life. I am an also an international global messenger. I have been to World Games in Greece, South Korea. I have swam in China, Ireland, Italy, Portugal, Mexico, in Down Syndrome World Competition. I hold 32 world and American records in swimming. Special Olympics is the greatest non-profit in the world for children and adults with intellectual disabilities. Keeping ourselves fit is the name of the game. Thank you.
As you can see, we really have some special competitors amongst us, and in fact, the raffle, I think, Eric, they can still go on. Yeah. So 7:30, you can go to the Fit Triathlete website, and you can contribute and put yourself in a raffle for that incredible. So it's 7:45, so up 7:30, and then those proceeds will go to Special Olympics to support athletes like Andy and others that are here today, because really a lot of times, and athletes of all levels have this problem, is funding themselves to be able to go compete. When I was at college, I couldn't afford to go to rugby games and some water polo matches because it wasn't a varsity sport, so I can relate, which we had a raffle back then. And so you're going to be really doing something important. So our next speaker is Justin, who's going to speak about how some of these athletes can have access to the kind of care we've talked about. So technology is always. Let me just say a few words about technology. A lot of people don't know where we're at. This actually used to be a flour warehouse and distribution center, and We're actually in our 10th anniversary now. I think Eloise is here. She's our office manager for the Mark Center. But this was, until last year, the world's largest cadaveric surgical training lab. So some of the things that Dr. Herrera spoke about, I mean, you can't just read that in a textbook. So on any given day, there are courses here where surgeons come from really all over the world. About 40% of our participants are from abroad, and they get to have some didactics in this room, but then go to the laboratory, which, as I mentioned, it's the second largest in the entire world, and we have it right here in Doral in Miami. And they'll practice this on a cadaver with certain exercises so that really we get the hands-on training. And this was started by a group of us who realized that going to hotel ballrooms to do these courses just didn't seem to make sense, and we thought that would be an opportunity. So it's been almost 10 years now. So I can introduce Justin while that's keying up. Justin's, some of you may not know, but Ortho Now here in Doral is one of, I think we'll have 8 in South Florida by the end of the year. It is a franchise, a healthcare franchise, much like Doctors Express, which you may have heard of. It is actually the only orthopedic urgent care franchise in the world, in the country right now. And Justin's our CFO, so our Chief Financial Officer, because you can imagine launching a business like that. The economics of it is pretty daunting, and I think today he had 4 or 5 different conference calls. One is a pediatric orthopedic group in northern New Jersey. I met with them 2 weeks ago, and they want to put 2 right away, and they eventually want to have 5 in that, and again, we'll have 6 in the Miami area by the end of the year. Do you want to plug in directly, maybe? So this franchise was launched almost 2 years ago, and all of a sudden it's kind of popped. So it's something you'll see, and what our hope is, athletes like whether it be Special Olympians or triathletes or CrossFitters, will understand that when they have say a painful hip, that they might not go into the general urgent care center where they're going to see perhaps a very, very good physician but doesn't have expertise in orthopedics. It's kind of like coming to me because you have blurry vision. It just doesn't make sense with the depth of knowledge that exists in medicine. So the idea of Ortho Now is to be able to have almost direct access to subspecialists like you just saw, and that's really the goal. So you can help us with that in just basically talking about it, participating in events like this, because part of it is education and community support. All right. So without further ado,
thank you, Doctor. Eric, can we maximize that? Okay. So I'll echo a lot of what Dr. Padilla said, and hopefully go into a little bit further detail. There's an old saying that says there's nothing like an idea whose time has finally come, and Ortho Now is definitely one of those ideas. By way of background, it's not only an orthopedic urgent care center, which means that all we see is sports injuries and orthopedic cases. But we at Ortho Now are the only ones that's actually doing this on a nationwide and international level, and putting a real business model behind it with a real outreach to patients, and providing a better solution than there's ever been for orthopedic care. Like Dr. Padilla said, it was established in 2013 in Doral. I finally see what it's like to have the microphone on. Okay. Shortly after we got going, we started getting a lot of attention and very credible attention. And so this is the cover of Entrepreneur Magazine. We were voted one of the top franchises in 2014. And I don't think we knew it at the time, but we were somewhat enterprising, not only in starting a new business, but in starting a new healthcare business, number one, but then a new healthcare business that was also going to be a franchise, and it started to pick up steam in the press. Like I said, it's an all-in-one package. It is not a triage center. If you go into the ER with a ankle injury, you'll be triaged, but you'll need to go elsewhere for final treatment. OrthoNow is a treatment center. You come in with a sports or orthopedic injury, you will be treated the right way the first time around. And it's better for the patient, it's better for the system. It's just really a better solution all around. We have specialty care, fractures, strains, sprains, contusions, dislocations, and concussions. And we staff it with experienced orthopedic or orthopods. So you are seeing somebody who knows your case. I get the question a lot, well, you know, there are general urgent care centers all the time, or I see them growing. There's one right by my house. Why would I go to an orthopedic urgent care when this one's real quick? And I said, well, would you ever go to your family lawyer with an IP question? It's sort of the same thing. Yes, they're both lawyers, but you'll end up spending a lot of money and needing to go elsewhere. And they seem to get it. And like Dr. Padilla said, we are selling these things rapidly. It is a franchise. And what we have found is that the majority of people that are interested in buying a franchise are interested in rolling it out in an area. So they're not interested in just having, let's say, one in Doral. They're interested in having 5 in South Florida. Can we go to the next slide? Oh, sorry. This is what your choices were before OrthoNow. If you were injured on the field or you were a weekend warrior and you got injured, you really had to pick your poison. You had to go to the ER, in which case you're in a lot of trouble, or you'd have to go to the urgent care center, and at least you would have a cup of coffee and you would sit there in a nice environment, but at the end it was still the same thing. You would be splinted, let's say, and you'd walk out with a sheet of paper that says, call these doctors, like Dr. Herrera or Dr. Padilla, and then you need to get on a waiting list, and it's very hard to get the right treatment. And what we set to do with OrthoNow is just disintermediate that process. I like to look at it with a slide like this, which I think succinctly captures the value proposition that we give to patients. Before, you had to make a trade-off. You either had to pick between good care or ease of access. If you wanted high ease of access, you'd go to the urgent care center. If you wanted good care, you'd have to wait and go to a specialist. And like I said, if you ended up in the ER, you were really in bad shape. And there was this wide open space to provide specialized care for orthopedics that was timely, that was professional, that was expert care, and that was easy to get to. And that was the genesis of the idea of OrthoNow. That's the space that we're playing in. And that's why we're turning heads. From a patient flow perspective, OrthoNow, when set in the sort of portfolio of a traditional orthopedic practice and a surgery center, really starts to congeal all the different ways that you can get care, because OrthoNow is really the first stop for care for patients. And once they come into OrthoNow, because I was saying this is a treatment center, everything is sort of pre-baked. It is one-stop shopping, right? So patient comes into OrthoNow, is worked up, and they could end up in the ASC if surgery is indicated. Any sort of imaging that's needed can be taken care of on-prem. If they need rehab, traditional rehab, or rehab replacement or supplement, which I'm sure Dennis will talk to you about, we do that on site, and you walk out mainly or mostly 75-90 minutes, and you're a happy camper. Good care is obviously at the forefront of everything we do, and that's something that we instill in all the franchises that we roll out. So the patient pledge that we make to everyone is that we're always going to be accessible. When you are likely to get injured is when we're going to have our doors open. When you come in, you will see somebody who knows how to treat your condition. You won't be referred out. We strive to get everyone in and out in 90 minutes. That means walking in and walking out, imaging, casting if needed, seeing the doctor, seeing the PA, 90 minutes total. Always friendly, courteous, and I think we do a pretty good job of this. We found that about 25% of the patients that come to see us the first time heard about us because somebody else recommended that they go to Ortho Now. And high quality, and it's economical. Before Ortho Now, I had to go to an urgent care center. I walked out with an $800 bill. That's certainly not economical. You could get the right treatment at Ortho Now for a fraction of that. And like this says, it's far superior to the hospital ER or general urgent care center. And that's the Ortho Now model. Just like I said, and like Dr. Badia has been talking about, it is a franchise. If you or anyone you know is interested in buying a franchise and being an entrepreneur, do let us know. The best way to reach out to us is at info@orthonowcare.com.
I think I'll introduce Dr. McCormick. We had been a couple, maybe after the next two presentations we'll do a question and answer at that point, because I think there's going to be some questions after Dr. McCormick's presentation, which is going to be, it's actually very interesting because a lot of buzzwords right now. I get asked about stem cells probably every 2 or 3 hours in my office during office hours, and then PRP has been a buzzword, so we're going to hear a little bit about the place of these orthobiologics in the triathlon world.
Well, thank you. My name is Frank McCormick. I'm part of the Lessons Institute. I also work at Ortho Now, and I've been studying stem cells for about 10 years. I first started out in the laboratory where I was actually taking fat and turned it into cartilage, and I thought this was the alchemy of modern day issues because osteoarthritis is so prevalent, especially in our population where we have young, active athletes, especially triathletes, who are beating up their knees. So I thought that we would talk about triathletes and knee pain and focus on stem cells and the use of PRP. So the truth about stem cells, this is a general overview of what I want to talk about today, but in the interest of time, I'm going to take it down into 3 key points. Well, first, I'm going to narrow it down to just about stem cells in relation to knee and knee injury. There's all kinds of stem cell treatments for hair loss, the Dracula facelift, for all kinds of things, and it may be the new it thing, but I want to just narrow our focus of effort on the knee. So I want to provide just general overview of what is stem cells and what is PRP, and then what are the results? Does it actually work? And then finally tailor up with some new interventions that we're able to provide at Ortho Now and the Les Institute that would really tailor to the athlete who wants to get back and treat their knees in a fast, efficient manner. So stem cells, mesenchymal stem cells, there's all kinds of controversy and ill-defined aspects of what exactly a stem cell is. And if you went back 10 years, it was very controversial politically with embryonic stem cells. The church got involved, politicians got involved, but the scientists, we actually figured out that our own stem cells are probably the best and quickest and most efficient way to do it. So what we look at, if we break down the connective tissue, which is essentially defined into bone, cartilage, connective, and fat cells, we look, and that's especially relevant to us as orthopedic surgeons because that's what we treat. We looked at the stem cells are all basically broken down into mesenchymal stem cells, and we can direct those stem cells into those 4 different characteristics and how to heal. And what's especially nice is that those stem cells are primarily located in bone marrow and also fat, so those are easily for us to adapt, and there's plenty of it available. So what is PRP? PRP is actually something different. So platelet-rich plasma is PRP, and platelets are in your bloodstream. And what platelets do is that they're full of growth factors, and we like to isolate those growth factors to stimulate the healing process. Orthopedic surgeons and doctors are actually getting a lot smarter as we're starting to figure out the body actually knows how to heal a lot better than surgeons. So we're actually using the body to heal, and we're having new good results compared to tradition. So the way I characterize it in the office when I'm talking to patients is, if we were to fall and break our arm, we could be confident that that bone would heal itself over a period of time. If we cut our hand, we're confident that the skin is going to heal over a period of time. Well, why is that not the same with the knee and cartilage? Well, if we fall and break our arm, we know that the first thing that happens is we start to bleed. And in the bleeding is the platelets, and those are the first things to act, and they stop the bleeding. But they also secrete growth factors, and that growth factor secretes the healing, begins the healing process. And that growth factors call in the stem cells, and the stem cells repair itself. Why does that not work in the knee? Well, unfortunately, there's no blood supply in the knee. So if we're going for a run, we trip and fall, we have an injury, unless there's a fracture, we're not delivering any healing products to the knee. So we have generalized degradation or breakdown of the cartilage. So as surgeons, we're trying to get a little bit smarter and bring the healing process to the knee. So a couple of examples of easy ways to do this, and this is something that we can actually do in the office while patients are awake, is we can take the stem cells from the knee. So here's a picture of a patient where a small needle, and small is relative because I know it looks pretty big, but we're drawing the stem cells out of the bone marrow, and we can also take it out of the fat, whether that's in the knee or different areas that you want to kind of tighten up. That's an option too. But then we take this and we concentrate the stem cells, and we can re-inject that later on. So here's an example of a patient getting the stem cell re-injected into their knee. So it's nice and easy, and this is something that we're actually able to do in the office, and the patient's able to walk away. In addition, new technology that we're able to bring to the Les Institute in Ortho now is in-office arthroscopy. So we're actually able to place a camera the size of a needle into your knee when you have an injury. That way we can look at it right away. And the picture on your left is actually the inside of the knee that we're able to see. And the patient's awake, they're under local anesthetic, and they're able to make decisions to see what's exactly going on inside their knee. And I like that because I can see what we have here is intact cartilage but a meniscal tear. So then I can take my needle and inject the stem cells directly into the meniscus, not have to just shoot it into the knee and hope the stem cells get there. I can actually put it at the site of injury. And now recent evidence suggests that this actually is reparative meniscal and opportunities and enables the meniscus to regrow. So very exciting things that we can do. And this is very nice because the patient has no anesthesia. They can go back to the playing field right after they leave the office. So very exciting. So as we go into this, we say, okay, stem cells sound great. They're very popular. They're actually growing at 40% each year, and they're supposed to be a $500 million market in 5 years. So you're going to be hearing a lot about it, especially direct to consumer. But does it work? And the answer says, at least for the knee, it seems that it does. So if we look up here in the scale on the upper right, we can see the pain. So when you go to the doc, you usually say, oh, how bad is your pain? 0 is no pain at all, and 10 is 10 out of 10, like you're having a baby. And you can see the patients that are coming in, they have a pain at a 4 or 5. That's pretty reasonable. That's a lot of pain. And then if you track that down, even up to 3 years, you're going to see significant relief. Now, it's not a cure-all, but it enables you to go back to doing your activities with minimal downtime in maintaining all your body parts and potentially regrowing it. And more importantly, if you look at the graph on the bottom right, you're getting back to your activities. So here is the level of what we say is your lower extremity treatment. You're at 40%. And over that time period, even up to three years, you're having significant gains. So we're demonstrating that stem cells actually do work. Also, PRP. This is another cost-effective intervention where it's just drawing your blood. You don't have to have anybody stick a needle in your fat or your bone. This is an easy, quick alternative, and it takes 15 minutes in the office. And we're finding this too is an effective treatment. I find it takes about 3 months to really kick in, with the maximal benefit is at 6 months. But at the same time, it's quick and easy to do, and you can always come back for more if you like it. Importantly, this is not a solution if you have end-stage disease osteoarthritis. Sometimes I do find benefit in it. I have about a 1 in 3% chance, and if the patient wants to take that risk, I think it's reasonable. It's actually cost-effective for me to do that, but we have to kind of set expectations appropriately. It's not a cure-all for everything. And then this is just another study demonstrating your overall improvement in quality of life. And you can see at about 1 year is when you really maximize your benefits. But we can see that stem cells are actually providing a beneficial effect for pain in the knee. importantly, as we are in 2015 and in Obamacare medicine, we're very interested in value-based orthopedics. So what's the best bang for your buck? What I want to see is how can I make you better but at the minimal cost? And if we look at this ratio, using stem cells for osteoarthritis, mild to moderate, is actually the best bang for your buck. So we're trying to pitch that to the insurance companies, and they may be starting to listen pretty soon. So that's kind of exciting. Oftentimes, so this is a bit of a gross picture, but as we expand, some of the things that we have here at the Les Institute in Ortho now is actually we're taking stem cell injections one step further, and we're actually able to do cartilage transplantations under a minimal incision coupled with stem cells. And I think this is going to be the next era that we're leading the charge with. You say, we look at this. This is actually an NFL linebacker who had the procedure done in January. Small incision, less than a centimeter, and he was back on the NFL field, made the team in August. So this is very exciting stuff, minimal downtime, minimal morbidity with surgery, and it's something that I'm very excited about, and I think that you're going to see a lot of it in the next 5 to 10 years. Thank you.
Thanks, Frank. I think the value here is that we still don't know, the jury's not out completely on the efficacy of a lot of these things, but the problem, I think, is that the public education has been lacking, and one of the goals of Ortho Now is really to bring this so that patients say, okay, there's one place I can go to, easy to get into, and they're going to be on the cutting edge, and then I'll be able to discuss the options with that orthopedic provider. So that's the goal. So in the same vein, I'd like to introduce Dominic, who's a foot and ankle surgeon. Dominic Lewis practices up in Aventura and works closely with this concept of ergodynamics, which he's going to go into, and which is, I think, particular for the runners amongst you.
So hi, my name is Dominic Lewis. I'm an orthopedic surgeon, also based in Aventura. My specialty is problems of the foot and ankle, and I just wanted to introduce you to a sort of a new thing that we started doing, I would say about a year ago. We sort of coined this term, ergodynamics. Ergodynamics we use to describe the motions of the foot, the way the foot moves in relation to the body, and what it does to the body. So it's really, if you think about it, we think about it from a functional perspective. So it's not just, like if you're kicking or something, but it's more for like what it does when you're walking, when you're running, and so on and so forth. We actually also look at it with regard to cycling also, which would appeal to the triathletes amongst us also. What we're trying to do essentially is using the foot as a platform to obtain balance, alignment, and functionally to improve your efficiency. So, for our older patients who we're worried about more degenerative stuff, we're trying to improve their function. For the purposes of athletes, we're trying to improve efficiency. If you think about it, if you're more efficient in your motion or in balance, you're likely to perform better. So it's not like a performance enhancement like steroids, but functionally it gets you better. So what we do is, I'm going to kind of take you through the process of what we do. When we see a typical patient, what happens. So patient comes in, they have foot pain, or sometimes it's not even foot pain. They may come in with knee pain, they may come in with back pain. I could use myself as an example. I don't really have foot problems. I operate on feet and ankles, that's my specialty, but I don't have foot problems. But I found that if I had like a full day in the office, or if I had a full day operating, by the end of the day sometimes I'd have a little back pain. I never really knew why. I'm also a doctor, so I don't really like to see doctors. So I never really looked into it much. And it turns out, well, I'll go back a little bit to the company, where the company is actually from Barcelona. The company is based in Barcelona, and I refer a lot of patients for orthotics because that's what I do, but I've always had an issue with the way that they are conceived. generally, if you go get orthotics, what happens is somebody puts your foot in a styrofoam box, or they may make a cast molding of your foot, or if you go to a more modern place, they may do like a 3D molding of your foot, and then they make an orthotic based on that. But I always felt like when patients came to see me for orthotics and they got orthotics, it became labor intensive, because what would happen is they'd come in, I would refer them out for orthotics. I don't really do it in my office. I would refer them out, they would go out, they get this cast molding of a foot like while they're sitting like this, and then they come back to see me and they tell me, well, it still hurts. Well, if you think about it, a foot, if you're sitting like this, is with no weight on it or anything, is very, very different from a foot with weight on it. I mean, it's natural to think. I mean, the ligaments, and they have some elasticity. So, you know, the foot without pressure on it is very different from a foot with pressure. It is also different if you think about it from a foot in motion, you know. And I always felt like we needed to find a better system that could take all of these things into account, which is what ergodynamic is doing. So I'll kind of explain it to you by taking you through the process of what we do. So generally, a patient comes in, like I said, you know, I have pain somewhere. And, you know, we go over their history with them, you know, how long have you had the pain? What is it from? What kind of activities do you do? Are you a runner? Is it at work? Or, you know, when do you get this pain and how can we help you? And, you know, once we get all of the history, we start taking them through our process. So the first step of the process is actually we get them on a treadmill, because we're trying to understand what your body is doing, what your foot is also doing in relation to your body as you're in motion. So we have cameras set up and we have you on a treadmill. For the ones who like to run, for the people who have pain when running also, we actually get them running too. We do it while you're in your shoes. We also do it while you're barefooted, because we want to see the gait patterns that you have, like what happens when you walk, what your foot does when you walk, what's your knee doing when you walk, what's your hip doing when you walk. We take video, we take lots of photos, and we see all of that. The next step is we actually do what we call the static examination, which is where we just get you to stand up in, you know, a functional anatomic position, and we're checking your alignments, like if your knee is bowed or if it's the opposite way. If you stand with, you know, like if you're leaning to one side when you stand because maybe you have a little bit of scoliosis, if you have a little bit of a leg length discrepancy, all of those things that we're looking for. Once we see those things, we, you know, well, this is also part of the static examination where we actually, we're checking for leg length discrepancies. We're checking to see if you have any anatomic abnormalities. For example, if your tibia is longer on one side than the other, if the femur is longer, we're checking all of these things. We're checking the hips, we're checking the knees, we're checking the back to see if you have scoliosis or anything. Then we get you on foot pressure monitors. So this is a monitor where as you walk across it, it checks the position of the foot all the way through the cycle. So you'll see if you see that picture up there, it kind of shows you where the pressure goes in the foot as you walk. So it's not only a compilation of the full gait cycle, but we could also run it where we could see at every second as you walk exactly what is happening to the foot. So once we take you through that process, you know, we sit down and we analyze it. We analyze it and we actually go over everything with each patient. We sit there with you. The whole process takes about half an hour or so. We sit there with you and we tell you exactly what we saw. When you walked, we noticed that you have whatever abnormality of gait there is. We notice that your foot, you know, maybe the left foot is a little flatter than the right foot. We notice that we checked and we know that you have a leg length discrepancy, which may be contributing to this. Your knees may be having a abnormality. It could be either static, as in when you're standing, or even as you're walking, we could see abnormalities. We point all of these things out to you, and then our real goal, what we're trying to do, is to try to correct those things and get you back into better alignment as well as better function, but using an orthotic. So the orthotic itself, which is what the real impressive thing about the whole process is to me, is the orthotic itself. We have about 30, because like I said, this was started about 30 to 40 years ago in Barcelona. We have a lot of data of patients that have been helped. I was fortunate that I actually went to Barcelona when to check out the company, because I actually had to see it to believe it. I'm not going to. I want to see the science. The science is most important to me. So for me, what it did was it actually helped me with the back pain. I don't have a foot problem, but I get some back pain. I started using the orthotics. I don't get back pain. I have lots of patients who have since gone through the whole process, and it, like I said, it helps with everything from, we go from all the way from foot pain issues, knee pain issues, ankle issues, hip issues, and even back issues. Any kind of problem that you could conceivably think of, we can help. Now, is it a cure-all? No, it's not a cure-all. I mean, I'm an orthopedic surgeon. I still operate on people. So it's not like, it's not a replacement of any type for what we as orthopedic surgeons do. It's more of an adjunct to what we do. So in the same way that certain operations help, or stem cells, PRP, it's an addendum or an adjunct to everything that we do. And we started here in Miami about a year ago, and we actually partnered up with the Dolphins. One of our patients is here. It's Caleb Sturgis, who is a kicker for the Dolphins, and he has used our orthotics. We have lots of runners. I would say probably most of our patients these days actually tend to be runners. As you would expect, they tend to have the most issues, and again, they want to be as efficient and as good athletes as they can be. Most of them tend to be pretty competitive. So I would say, and we have different surfaces, different materials, so it's more than just the orthotic. We have to, each orthotic is personalized. It's not one foot. It has to be both, because you have to balance each patient out thoroughly. We also do flip-flops, as you see there, which use the same technology. So like I said, we take care of many different problems. We are here, we are set up in my office in Aventura. We also have an office in Coral Gables. We have an office we have several offices, I would say, around Spain. There's an office in London also, and we're looking to expand kind of in the same way Alejandro is. And we'd be more than happy to talk to you. We have people here. We have our lead analyst, who is Doctor of Physical Therapy there. He's here, and we have a table set up here also. Anybody has any questions, we'd be more than happy to answer. Thank you very much.
Thank you, Dominic. Actually, I took the test myself. I always knew I was fairly flat-footed. I was told as a little kid I'd never be a good runner. They were actually right, but I will say that the treadmill analysis is pretty interesting to see your gait, and you can see a lot of very subtle things, and it's actually amazing to me that people who are doing these kind of long endurance events may have no clue about their gait cycle, about the biomechanics. So I'm very flat-footed on the right side, and yet not so much on the left. And if I was doing ultra marathons, I mean, that would be critical. So this is something that we also offer at Ortho Now. I think every Thursday, ergodynamics is there, and you could just come to the center with no appointment, and on a Thursday, and have an analysis. So the importance of all of this will be brought to light by Dr. Amanda Stevens, who's not only a triathlete, large distances, but also an orthopedic surgeon herself, and she's on the other side of the country by Google Hangout.
Okay. I guess Amanda. Like Dr. Padilla said, she's a doctor and a professional triathlete. She's going to talk about preventing triathlete injuries and when to seek an orthopedist. Good evening, Amanda.
Good evening, John. Thanks for the intro, and thank you to Ortho Now and Dr. Badia for having me here tonight. It's just a pleasure to be speaking on not only this panel, but to all of you out there. Oh, waiting. Up. Can you not hear me?
We can hear you.
Okay. So anyways, as they pointed out, I'm not only a physician, but also a professional triathlete. So I have experienced both sides of the coin, not only treating patients, but being the patient myself. And there's all these great treatment modalities out there, but as an athlete, the last thing we want is to be injured. And so I'm going to talk about those times when you have an injury and you're not quite sure if you need to go seek professional help, seek out a specialist, and the times when you definitely need to get in there and see somebody. You know, in triathlon or in any endurance sport, we're putting our bodies through a lot of rigorous things, and we want to keep things balanced and healthy and keep going out there and setting PRs. So when it comes to injuries, I usually classify them in two different categories. There's kind of the traumatic ones that are injuries, they're acute. It's accidents, you know something happened and something could possibly be wrong. And then there's the other ones that are non-traumatic, and these usually develop over time, most likely in the form of overuse injuries. So first we're going to hit on those traumatic accidents or the accidents. And when those occur, the quicker you can seek medical help, the better not only treatment you're going to get, and especially going to a place like Ortho Now, you're going to get the specific treatment that you need immediately. So your outcomes are going to be better, and you're going to be able to hopefully heal 100%. You know, if you wait around too long, then your chances of 100% recovery, they go down. So I'd say in triathlon, one of the biggest accidents that we see is unfortunately on the bike. You know, and Mr. Anderson mentioned this earlier, so be safe out on your bikes and definitely always wear your helmets. And when those accidents happen, usually it's a highly intense emotional thing, and you get an adrenaline rush. And so sometimes, you know, you pop up, you think you're okay, you run over, you check your bike, that's usually the first thing we check. And then you kind of look at yourself and you're like, oh, I'm fine, you hop on your bike and ride on home. So when you have these accidents, it's always good to kind of have, you know, a friend, a family member also take a look at you and see, because sometimes you're on that high of an accident and these things, and you think that you're okay. And like I said, getting in there and getting treatment it's the name of the game. That's how you get back to 100%. So if you end up cracking your helmet, definitely that's number one. I don't care if anything else is, nothing's wrong. You think you're okay. If you have cracked your helmet, please go in and get evaluated. I've been in several accidents myself and had the cracked helmet, and definitely you want to go in there and get treated. And then since we're on where your head is with the helmet, we're going to go with some head symptoms that you might have. So if you have any confusion, if you suspect a concussion, if there's loss of memory, if you actually blacked out or feel lightheaded immediately afterwards, if you're experiencing any neck pain, slurred speech, nausea, intense headaches, any bruising of the face, and if you're kind of losing any fluids, whether that's blood or clear fluid from any holes in your face, which would be your ears, your eyes, your mouth, your nose, definitely, you know, get in there and seek some help. And then we're going to speak about the chest region now. So any chest pain, any bruising in the chest, any difficult breathing, or if you feel shortness of breath, those are some other good indications to, you know, seek out a specialist immediately. When it comes to the abdomen, look for protrusion, any swelling there, and also be on the lookout for blood in your urine or stool. And then when it comes to the rest of your body, I mean, you might be outside and running and you twist your ankle. It's winter now in most parts of the country, so maybe you're doing some fun off-season activities such as skiing. You know, if you have that sudden accident there and your knee goes out, some things to look for are numbness, joint swelling, loss of motion. Definitely if you suspect a fracture or if a dislocation, if your shoulder's hanging off like this, probably a good time to go in and see that orthopedist. Also, if you have any extensive bruising or road rash. A lot of times we try and just clean up that road rash ourselves, but the last thing we want is that to get infected, especially if it's over a joint. So those are some things that are pretty common sense, but I think, again, as athletes and some of us that are also physicians, the last thing we want to do is go seek out help and go to a physician, but they're the ones that can get us right back on our feet. Now we're going to look at the other side of injuries, and these are kind of the ones that are most classified as overuse injuries. And these typically come on, they have a slow onset. Sometimes we're not quite sure where they came from. And so when I look at these type of injuries, I usually classify the pain into 4 different categories. And so depending on what level of pain you're at, that's what depends on how you're going to treat it. So kind of my pain levels are, the first one is a niggle. The second one is an apparent pain. Next up are pains that interfere with your daily living. And then any pain, the final one is any pain that's causing you to take pain medications. So we're going to go through these pretty quickly now. That first one I said was a niggle. And so that's just basically if something doesn't feel right and you actually notice it, that's kind of like the alert going off, your body saying something is not right. And I think Dr. McCormick mentioned it early and said, you know, our bodies they're made to heal themselves, and they're very smart at that. So when you get that warning sign, you know, stop and listen to your body. I coach some athletes, and I do this myself. If I get a random pain, it's 3 days off from the activity that is causing that. So let's say you get back from a run and your knee was a little off. No running for 3 days. You might be able to hop on your bike and it doesn't hurt. Great, go ahead and keep riding. If it hurts on the bike too, take 3 days off from that and just get yourself to the pool, or just don't train for those 3 days. And then also during this 3-day break, I really encourage you to evaluate what caused the injury, because a lot of times you can figure it out yourself. You know, look back over the last couple weeks, and if you've made any major changes, that's something you want to look at. You might have changed your bike fit. You might have gotten different running shoes. You might have started playing with a new pool toy, such as paddles, that cause your shoulder to start bothering you. So go back and look at those the past few weeks and see if that could, you know, have brought on this little bit of a niggle. And when you do that, then, you know, go back to what you were doing before, and if that cures you, then, you know, great. And if not, also during this time, I encourage you to look at your stress levels. So we are bombarded with stress every day in all different directions, and it comes not only from training, but also from the environments we're in. So I know a lot of you were in Miami traffic. That's got to be a stressful situation. I was there in October, and, you know, it drove me nuts. So that just increases stress. Not sleeping, nutritional stress is not eating the right things, and, you know, not getting those nutrients that were mentioned earlier. So just look at all these things, because your body wants to stay in balance, and stress gets it out of balance. And when you're out of balance, that's when your body tries to talk to you through these little pains or niggles. Now let's say you couldn't figure out what it was, or you didn't take your 3-day break, and it becomes an apparent pain. Now, an apparent pain is usually one that starts while you're working out and it gets worse, or when you're done training, then you feel it. So pain after training, or pain that becomes worse while you're working out. And this is when you're like, okay, I really have something going wrong. When you're at this stage, if you didn't take a 3-day break the first time around, take that 3-day break now. It's pretty imperative, and I think if you actually stop and let your body try to heal itself, it usually can do a pretty good job of that. And some things during this period that you can do to kind of self-manage is, you know, to massage the area. You can do some active stretching. Passive stretching I don't recommend, but some active stretching, trigger point work is very big right now, and there's definitely some alternative treatments out there right now, such as acupuncture, active release therapy, people that work on soft tissue. There's also some great devices. I think we're going to hear from Mr. Thompson here pretty soon about one I just learned about tonight that sounds pretty interesting. And then I use compression boots, and also it's just a good idea to elevate whatever's injured and bothering you. You know, chill out and get that elevated. So now we're moving on. Let's say you haven't quite figured it out. You've been self-managing and you still have pain, and now that pain is interfering with your daily activities. So maybe you notice it walking, you notice it sitting at work, or it's waking you up from night, waking you up at night during sleep. This is definite indication. This is the line where you go and you seek specialist, and Ortho Now is the place to go do that. You get the specialist right away, and you can get treated. So if it's interfering with your daily life, get in there and see them as soon as possible. And then the last level of pain was if you're taking any pain medications whatsoever. This is another pretty clear line. When you're taking that pain medication, it's your body saying something's not normal. And most pain medications that we take, it just masks the injury, and so you don't feel pain. Sometimes it might help a little bit with inflammation, but you still have some sort of reaction and stress going on. And so you're masking what you feel, but you're still injuring it on top of it, and ultimately making it worse. So we don't want to put those fake Band-Aids on there. We want to go in and get the real help we need and get healthy. So hopefully this helped you guys out. Know the difference of when to kind of step back, evaluate, take a 3-day break, and treat yourself, and when to get in there and see some specialists. So I encourage you to go out there and not only get healthy and stay healthy, but train healthy, and then you'll race really fast. So thank you very much.
Thanks, Amanda. Good luck in your next race.
Thank you.
Okay, moving along in the Hangout portion of this program, we have Dennis Thompson. He's the inventor of the ARP Wave. It's a medical device that provides neurotherapy for athletes and also triathletes. Welcome, Dennis.
Well, thank you, everyone. As John said, my name is Dennis Thompson. I'm the creator of a new therapy that we call neurotherapy. It is a direct supplement to physical therapy. All the doctors that we've heard from today, all the therapists we've heard from today are addressing all of our issues exclusively as a physiological phenomena. Dr. Badia, Dr. Herrera, they work on the end point of where the problem ended up. So in other words, if you have a torn meniscus, if you have a torn labrum in the shoulder, they're going to repair that. That's the where. Neurotherapy is the why. Why did that happen? And it happened because the body was unable to neurologically turn on the muscle fast enough to absorb force. So I'd like every athlete in the audience and every doctor to think about wherever we have pain is where the problem ended up. Let's look at all of the venues that we have to identify where the problem ended up. X-rays, MRIs, CAT scans, ultrasounds, they all tell us one thing: where the problem ended up and the severity of that problem. Neurotherapy in the diagnostic side identifies exactly where the problem came from. So as an example, if someone has a knee problem and they're bone on bone, or someone has pain in the knee, for the most part, we're going to address the knee as the problem. This therapy is not new, folks. We've been doing this for well in excess of 20 years. We were the provider of these services. In that process now, we're aligning ourselves with physicians such as Dr. Badia and his organization, Ortho Now, and offering a supplemental therapy working on the where the problem came from. So let's look at a knee. If the quad muscle isn't turning on fast enough, it cannot absorb shock. If it cannot absorb shock, the shock is going to go to tendons, ligaments, and bone and fascia where it's not designed to go. So if you want to get rid of that problem, transfer the force out of that tissue and put it back into the muscle where it goes. The trouble is we as human beings can't do that on our own. So therefore, we have to have a therapy which breaks us of that pattern of movement. So if you've ever sprained your ankle or had knee pain or shoulder pain, I guarantee you changed your pattern of movement. If it hurts on the right, you move everything to the left. We can give you pain medication, or we can completely anesthetize you and bring you back out And I guarantee you're still going to have that same pattern. It doesn't hurt, but you still have that same pattern. That pattern is not a physiological pattern. It is a neurological pattern. So what we do with neurotherapy is we re-establish a new pattern, a pattern of biomechanical movement. We talked about, I think one of the doctors was talking about the ergodynamic, I think is what it was called. Think of it this way. If the muscles are doing what they're supposed to do, and they're supporting us the way they're supposed to support us, would we have a need for an orthotic? And the answer, of course, is no. But everybody in this audience, if we just gave them a simple test that we do at OrthoNow, a simple neurological test, the overwhelming majority are going to fail the test because the body hasn't been trained through the nervous system to absorb force. So all of our athletes train to get bigger, stronger, and faster. Key word is bigger, stronger, and faster. That shortens the muscle. When a muscle is short, it absorbs 1/10 the amount of force it does when it's in eccentric contraction. So if we want to prevent injury and we want to train at a higher level, doesn't it make sense to train neurologically to get the muscle to function in that rhythmic dance between the agonist and the antagonist? It's when the antagonist is shortening and it should be lengthening is where a lot of our problems are. So at OrthoNow, we address it through neurotherapy. Patient comes in, they're exhibiting pain, they're exhibiting restricted range of motion. The first thing we do is we identify, is the nervous system doing what it's supposed to do? Invariably, it's not. So what we use our technology to do is get the nervous system to turn on the muscle fast enough to absorb force. Once we've done that, that muscle hasn't been doing that for quite some time, so obviously there's force going to tissue that's not supposed to be going there. So now we got to transfer that force out of that tissue back into the muscle. That is called neurological re-education. That's the second part of what we do. Then the third part of what we do is build the strength in the muscle to allow the muscle to continue to do and absorb those forces. In a nutshell, it is a new way of looking at an old problem. It's just looking at it on the neurological level, not just exclusively on the physiological level.
Okay, very good. Thank you, Dennis. Then it's back to Dr. Padilla, back at the Mark Center.
Stands for Accelerated Recovery Program. Has been something we've been using at OrthoNow for the past year and a half. It's an incredible adjunct to a traditional physical therapy. What it seems to do is work on the muscles, both eccentric and concentric contractions, relaxes them, and it's very good for acute injuries. We've used it at the CrossFit at Wadapalooza recently. We have the machines at the Ironman event, and I can tell you I sprained my ankle about 3 weeks ago. I was literally limping, dreading seeing patients because I'm running from room to room, and I had one treatment. Literally the pain was gone. And an unnamed basketball player here in Miami who's since left actually had a severe ankle sprain, had one treatment as well, and was able to play an Indiana Pacer game. So it is pretty amazing. If you want to see something about it, you can go to orthonowcare.com. But it's something that's been really in the realm of only elite athletes, and only now we have the opportunity through OrthoNow to bring it to the public. So it is pretty amazing. And it's a great adjunct after surgery. I'm using it after most of my shoulder surgeries, immediately in the recovery room, and the subsequent days until they start traditional physical therapy. So I'm going to speak on upper limb. So I'm going to try to go pretty quickly because we had a little bit of a late start. But so it was mentioned before, but cyclists end up getting a lot of the injuries that I might see, I'm pretty busy on the Ironman day. There's a number of shoulder and wrist injuries that come in, so I'm going to quickly go through those. So I have to admit I have a little bit of athlete envy here. I think these are incredible athletes, and that's one of the reasons I'm excited about getting involved. But there, I had the opportunity to meet Dave Scott in the bottom right, who's I think won 7 Ironmans in Kona. And all of these athletes have had their share of little injuries, of course. We talk a lot about prevention, and that's certainly, I mean, that's key. But when you're talking about the kind of injuries you get often from a bike, from a fall, it's kind of hard to prevent that. I think the only way you could prevent it is do this: just be a couch potato and not get on a bike. But if you're gonna, if you're gonna participate in sports where there is a possibility for a fall or being hit or whatever, I think what's really important there is just to get a really fast assessment and listen to what Dr. Stevens had said is the difference between the acute injuries and the chronic. And the chronic ones, the ones where they get to be constant pain, that's where you want to make sure you see the right specialist. So you see somebody who knows about hip, or you see somebody who knows about knee, as the talks that you heard. And if it's something about, say, wrist or elbow, that's sort of my area. So you can see this guy's probably going to need some care. I'm just doing that to wake you up. But my world is strictly from the tip of the finger to the shoulder, including the clavicle. In fact, I think he left now, but the gentleman sitting in the front row, I just put a plate on his clavicle about 2 hours ago, and he actually came with his brother, who's a vascular surgeon, and both of them are cyclists, and he fell off his mountain bike this weekend, went to ortho now, didn't go to the ER, was seen in about 20 minutes. They sent me the text. I was out of the country, and about 2 hours ago, I fixed him, and he saw the guy left in a sling. So part of that is a tribute to our anesthesiologist. The kind of techniques we're using allow us to do these kind of big surgeries outpatient, and he'll actually have minimal pain for the next 48 hours because of the cocktail that was injected around the shoulder. So what do you do when you get that acute injury? Well, it's already been mentioned. I mean, if you're bleeding from your ears or something, I mean, yes, call 911 because, we don't do, I mean, no urgent care, certainly not ortho now either. We'll do head injuries. We don't treat femur fractures. But then again, at that point, you're not ambulatory. So pretty much anything you're ambulatory, we can see. But, be wise about this. You want to have a splint on. At the Ironman, we saw the EMS did a great job of temporarily splinting people till we saw them in the tent. And from almost any injury, really ice, because what you're going to do is cause vasoconstriction, minimize the swelling, and all of these factors that will lead to the edema and secondary problems. So, and in the case of, again, the not so severe injuries, we have an app that I think there's a card out there, but I really think that every triathlete, runner, whoever it may be, should have this app. It's just, and you can even notify the center when you're on your way over. So there, this is the transition. It was exciting for me. And again, we were there treating them. Now, very different in ortho now than what you see in the ER. This is a skeleton. For any of you who've been there, you wait, but the worst part isn't just the wait. The worst part is unless you have a femur fracture, they're going to tell you see somebody like Dr. McCormick or Dr. Herrera, so you've ended up spending 6-8 hours and you still didn't really get the definitive treatment. So with shoulders, again, Dr. Stevens mentioned both overuse and acute injuries. The overuse, I can attest to that. When I was a swimmer in high school, I had so much shoulder pain, I ended up giving myself a chemical burn with Bengay. That was about all that was available at that time. But you would need to diagnose whether it's an impingement, a bursitis, tendonitis, or maybe a problem with the rotator cuff or labrum. The traumatic injuries are the ones that we see in the tent at the finish line, that the rescue guys bring them to us with AC joint injuries, fractures. These things do occur. In terms of overuse, I mean, it was already mentioned, rest, take some time off from that activity. If it's not getting better at that point, be seen, and you may need some formal therapy. We're happy that SportFit is here tonight, so these are our physical therapists who have particular expertise in treating sports injuries. We also offer that through Ortho Now, and we talked about ARP Wave. I'm very careful about using steroids, corticosteroids, because it does weaken tissue. When somebody's getting for a competition, we might use it once at a low dose just so they can get through that competition. In the same setting, we can also do the MRI. So one of the things about Ortho Now is we want to be able to assess a person completely. And here you see an MRI where there is a cuff tear. Let's see if I have a pointer here. You can kind of see that bright spot between the bone, which is black, and the tendon, which is gray. There's a little bright area, and that's where the supraspinatus actually tore. So when that happens, that really needs to be fixed. And all of these modalities, as you see here, may buy you a little bit of time with the pain. You might be like our friend who swam from Cuba to Florida, who had a small cuff tear. And I'm sure she did a lot of these treatments just to be able to do that. But at some point, Diana Nyad's going to need to have a cuff repair. Otherwise, it's going to end up getting worse, and she'll actually develop potentially a rotator cuff arthropathy, which is an arthritis. So about 25, 30 years ago, this is the way arthroscopy of the shoulder was looked at. This is a slide Gary Gartzman, a shoulder surgeon from Houston, gave me, and it was called by a guy named Charlie Rockwood, the instrument of the devil. And that was because literally there was a time when it was only accepted that arthroscopy was used for the knee. And now, I mean, I think there's very few surgeries we actually do open anymore. So we do it under a block. It's pretty much always an outpatient procedure, and there's a lot of different problems you can treat. So I was using a beach chair, then I went and spent time with a colleague in Milan who's one of the busiest shoulder arthroscopists in the world, and I radically changed. This is about 6 years ago now, and I do it all in this lateral position. You see the top, and that allows me to put the camera in, diagnose the problem, and fix it all in one setting. And in fact, it's so effective, that's me under the covers. I had it done myself. Like I said, I was a swimmer, but probably from some years of weightlifting, I had an AC joint problem, and they're doing a therapy. So, I mean, it's not as rough an experience as people would think. I did the same thing on one of the Olympic swimmers. So an AC separation is something you hear about this on, in sports on TV. So had a shoulder separation. That's very different than the dislocation. That means that the collarbone or clavicle is separated away from the scapula, the shoulder blade, and you can see that big step off. You can see in the bottom right side how I fixed that with the device, and I want to thank Arthrex is here, which is a company that makes a lot of the instrumentation we use for arthroscopy, and this is called the Tightrope. It actually allows me to drill through the collarbone and use this device to cinch down the clavicle and then repair the ligaments. And here's another example of a different modification of the Tightrope, and you can see the range of motion we got back. And these people go back to sports. I mean, the other guy was a rugby player from the Cayman Islands. Now, fractures is something we'll see also in cyclists. In this case, this was a motorcyclist, a motorcycle competitor who had 2 fractures in 1 year. Had a fracture, was on his motorcycle about 5 weeks, came in, had his wrist fracture, was back on the motorcycle in 4 weeks, and by the end of the year had broken his other collarbone, didn't bother going to ER, just literally walked into my office. Fortunately, I was in town, and the next day we fixed it. And that year he actually won the most valuable cyclist. Somehow he managed. So very much like triathletes, it's hard to keep these guys down. And there you see the scar. So that's the same exact incision I used on a fellow who was sitting in the front row a little while ago. And the only reason he got up, I heard, is he had to go pee. He had all the fluid from the arthroscopy and from the IV that's typical post-op. So anybody know this person? Or a lot of people now don't want to know him. I don't know how everyone feels. But so this is actually Lance's X-ray, a colleague of mine who fixed his. And he was back on a bike in about 3 weeks. So what I'm saying is it's not that daunting. The important thing is you want to really get the right opinion and get these things taken care of quickly, because then you can get back and compete quickly. This was mentioned previously. This is a labral. In this case, it's a SLAP. It stands for superior labral. So you can see the bicep where it comes in. It attaches to the top of the socket in the glenoid, and we attach it very much like the labrum of the hip, which you saw Dr. Herrera show. There's not time to show videos, but you can see we use anchors as well, and that's secured. That person will be in a sling about 3 weeks. We often are using ARP in them, and then we get them into PT. about the third week, get them mobilized and get them back. Probably can get them back on a bike in about 10, 12 weeks. Elbow injuries, a lot of them tend to be overuse problems, although I don't really like to use that term. I think it ends up being a lot of anatomy and your blood supply, your perfusion. I had terrible tennis elbow when I was a resident, and yet I didn't play tennis. I was a resident in New York, and finally it went away after a couple cortisone injections, but it was time. But people don't want to wait a year, year and a half if you're a competitive athlete. So now we have other options to get you back much quicker. We obviously start with all the most conservative modalities. I try to avoid steroid injections nowadays. We are using some ARP, and then in the really bad ones, I use an ultrasound ablation, which is a definitive treatment. It's an outpatient procedure. It takes about 12 to 14 minutes, and it's really been quite amazing with almost no post-op pain. Now elbow injuries can be more severe. You see there a fracture of the neck of the radius. The radius is one of the two bones in the forearm. It connects to the humerus, and you can see where it's collapsed there. Typical fall on bike. There's a picture I did some Photoshop too, so nobody would get grossed out, but I wanted you to see that we actually put a little plate on there, and it's amazing because with that plate, we start moving that person literally within 2-3 days. Just let the little soft tissue swelling come down, we get them moving, and something like this, that person can be on their bike literally within 3-4 weeks. And here you can see the motion. It's a small lateral scar, and they're fixed. Fractures can be more severe. Here's a really shattered proximal ulna, and this requires a plate. There's a motion. Here's one where there was a fracture, concomitant fracture to humerus. That's a big bone at the elbow. The forearm, and this was a gal who was doing that Century ride in the Keys. She fell, so I had to plate both the humerus and the radius. She actually had a fracture of the ulnar neck as well. So this is pretty complex fractures. But there's her motion. You see, sometimes we lose a little bit of the full extension, but oftentimes it comes back. But 4 months later, she was teaching spinning and back to cycling. So the point being is that if you have these injuries, as long as you kind of get to the right place, you can get back to competing. And it's very sad when I see an athlete who comes to me at 6 months later and really could have had a different treatment. They didn't simply because of lack of awareness. Now, they're not all so bad, right? We see little, in fact, I think, Justin, about the data shows about 30% of our injuries. So for any moms out there, or anybody who wants to go to Miami Children's and spend 8 hours, we see these kids in about 10 minutes. Most of them require a little cast, only for about 3 weeks. And these pediatric fractures constitute about 30% of our patient population at Ortho Now. So in terms of wrist and hand, wrist fractures, ligament injuries, there's a whole host of problems. Typically, these are in older patients, osteoporosis, but when you fall from a bike going 35 miles an hour, you may very well break your wrist. It's something that we actually developed in Miami, believe it or not, and it's now used worldwide. It's kind of the standard of care, the type of treatment. This is us in the tent, splinting somebody, examining somebody. This is at the Ironman downtown. So here's a particularly bad fracture. It's actually an open fracture. They used to call this compound. That's an old term. It's an open fracture where the bone actually pokes through the skin. But we treat it quite the same. This requires not a cast, of course, but it requires a plate. And this is what came out of Miami. As you can see, this plate is put on the palmar side, not on the dorsal side. And that's actually what revolutionized the treatment of wrist fractures. That came out of my old center with my previous partner. We came up with this concept about 12, 14 years ago. And it's really the standard of care now. So just to show you one example, very bad fracture displaced in a young competitor. Here's the plate. There's her range of motion. And we can get these people back on the bike in about 5 weeks. And there's a little scar on the right side. What we do is we move. This is some artistry by Dr. Eduardo Gonzalez, who's an excellent hand and upper limb surgeon here also in Miami. We were partners some time ago, and he's also a medical illustrator. And he's showing the muscle called a pronator quadratus. We lift out of the way. We put the pieces back. We put the plate on. And sometimes I even combine this with arthroscopy. You can see the scope in there just like in the hip. What it's allowing me to do is take that fragment, which is depressed, and elevate it through 2 little holes without even a stitch, and then put a pin in. And that's showing arthroscopy from the outside. So we went from the extreme of hip arthroscopy, which is the largest joint, to wrist, which was one of the smallest. And Dr. Herrera did mention that I also do a lot in the small joints of the hand. I want to quickly mention patients' hands will go numb while riding. I don't know how many cyclists are here, but it's happened to me recently, and as I'm trying to get into it. So I've noticed that usually it's my little finger, so that I know it's the ulnar nerve. But a lot of times you're putting pressure on the carpal tunnel, and it's not due to a computer. This is a computer in Cuba, although that may change now. Although I don't think so, but I don't want to get into politics. But this is a computer in Cuba, and it has nothing to do with carpal tunnel syndrome. It's actually a metabolic problem, but it's also an anatomic problem. So if you have a very tight tunnel, you may be predisposed, and if you're putting pressure on it with long rides, then you may bring on the symptoms. And it does require a diagnostic workup, obviously something that we do at Ortho Now, the initial conservative treatment. And when it's bad enough, the surgical treatment, it's very easy. Basically, you're seeing a cadaveric cut there showing the ligament. The big arrow is showing the ligament that's the roof of the tunnel. And all we do is divide that ligament. So you can do that either open, or you can imagine doing it endoscopically, much easier, much simpler, and I can get people back on a bike literally within days. I use a 1 incision, so I did 2 today, and it literally takes about 5-6 minutes. Local anesthesia, minimal sedation, and using the hand right away. There it is in my right hand. It looks like a little gun, has a fiber optic instrument, and then the blade that comes up and divides the ligament from the inside out. There you see a patient showing me on the OR table how he can open and close his hand. Arthrex also makes a device for dividing this. The last few years, I've also been doing my cubital tunnels, which means the funny bone. You know, we all banged our elbow at some point. It's very uncomfortable. You imagine living with that. Well, instead of making a big open incision, like a lot of our colleagues still do, a substantial group of us are now doing it all endoscopically. And you can see on the bottom right the small little scar. It's about 1.5 centimeters at most. This is a term I'd love to abolish, jammed finger. It doesn't mean anything, but you'll see it a lot in a basketball court. But when you fall from the bike, you might have what I call an axial impaction injury. It means that basically you drove your fingertip into a hard object, whether it be the ground or another player or a basketball, and you may have had a series of different injuries which jammed finger does not describe. So it can be a ligament injury, which would be called technically a sprain. It can be an avulsion of a tendon. It can be a dislocation. It can be a fracture into the joint. So here's actually I fixed one of these today that was almost a month old. It was a work-related injury. By the time it got to us, again, it didn't go to Ortho Now. They went to an occupational health center. By the time they navigated the system, I took care of it today, and I actually had to open it. Whereas if I'd seen them in the first 10 days, I wouldn't. This is a technique I described years ago where you take 2 little pins, and then the person has their finger cast. And I've done this on athletes, and they are able to begin competing almost immediately as long as they're wearing this little protective cast, and we remove the pins at about 5 to 6 weeks. A boxer's fracture, this is actually after you're celebrating from your triathlon, and you might get into a little scrap in the bar. You've had a couple beers, and you hit the wall, you hit somebody, and that's usually how this happens. It usually doesn't happen falling from a bike, but it can, and this is what we do. We remove the pins, and it's like it never happened. So all of these injuries are of the upper limb are of a big interest to us, and a group of us started this society. It was first started in Italy, and it's a worldwide. There's actually an app you can see on the phone. There's an app called iSport, so you can be anywhere in the world, and you can find the nearest person. I'm a therapist, right, Regina, who's a member of iSport, and so you could find that person. Say you're competing in Kona, well, you'd be able to find who in Hawaii does hand surgery but has a particular interest in athletic injuries of the hand. And I was proud to be the president a couple years ago, and our current president from Japan is an expert on tennis injuries of the wrist. So any questions, you can reach me directly. But again, reaching me is not the same. Sending an email is not the same as being seen, and that's why at Ortho Now we try to make it that no appointment is needed, and you could just kind of hobble in. So what can we do to improve care? Well, again, download the app and pass it along to fellow competitors. We have a Facebook page. Important thing is to get educated about this and get the buzz out, because the worst thing we can see is a high-level competitor end up getting delay in treatment, and that's something we want to avoid. Thanks very much. And I want to present, Virginia, you have some words to say. So one of the things I mentioned about getting people on the bike is obviously if you've had a plate in your wrist and you're still a little sore, you want to protect it, but you don't want to get stiff. And there's a pretty new device now that she's going to explain that allows you to do that.
Good evening, everyone. In regards to time and respect for everyone, I know it's about 20 after, so I'm going to do a 5-minute presentation in 1 minute. And Eric, if you want to go to slide 10 or 15. Basically, okay. Thank you, Dr. Badea and Orthonaut, for inviting me. My name is Regina Lafauve. I'm an occupational therapist specialized in orthopedic and neurological rehab for 18 years now. One of the things I got involved in as a therapist was looking at bracing and why we do what we do, not only for protection post-operatively, post-surgically, post-injury, but also getting the patient back to work, play, or sports. And thought long and hard about this. One of the things we do is we want to get them back to compete. We want to protect the injury or the fracture or the surgery, but then we need to grade that. We need to do that in increments. And controlled motion came across my mind. Why would we put a patient back in a splint, a static splint, if they've gained range of motion? Didn't make that much sense. If they gain the motion, let's maintain it and keep it going. So the concepts I'm going to present the next minute are about controlled range of motion. I'm going to skip over the investigations, and Dr. Badea could talk about this tonight for hours. So I'm going to go through this because there's a lot of things that can happen to the wrist. It's very complex, and we see a lot of them in surgery and hand therapy. The old way we used to do it is we used to take orthoplastic material and make splints. Someone talked about buoys in the water earlier. Actually, a lot of these orthopedic splints were developed from the same materials back when Smith & Nephew made them. Well, we look at the athlete today. We all know we have to protect and compete. So how do we do that but allow them to get back in the game? This gentleman and many of the NFL players who wear the Ortho Now splint actually was able to get back in the game. Had a cast on for 3-4 weeks. We got him out early. We set him at 40 degrees. So basically the splint allows you to protect the athlete, but it allows range of motion in a certain range. A lot of the supercross, motocross people all over the world utilize these splints. It's a very lightweight Kevlar base used in the military, so light enough that people can use it, but also is able to control extension, flexion, radial, and ulnar deviation, so all planes. So depending on what the surgeon will allow the patient to move, we just protect that amount of range of motion, and then we progress them forward. This look familiar? Again, what is the best thing to do? Protection is always the best defense. As a therapist, we know we have lots of modalities out there, but prevention, and prevention not only post-rehab, but these athletes have to go back to what they're doing. These orthotics are cleared to use in all professional sports. NFL uses them. They usually tape over them. So you see a lot of these guys with an orthotic on. It's this splint 99% of the time, because it's really the only one that allows certain degrees of range of motion while protecting the injury. So basically, I won't get into all the fundamentals. Luckily, they're available at Ortho Now, and there's going to be some trained experts there that can answer a lot of questions. But we have different versions, speed wrap, you know, a lacer version, all in the name of performance. They're lightweight, the palm is open, the patient can grip, go back to ADLs. So really, in a nutshell, how do we protect it but allow maximum function? This is one way that we can achieve that through an orthotic. And this just gives you the variable extension control, 20, 40, 60 degrees. And flexion, we control it in 10-degree increments to 50 degrees. We can block ulnar radial deviation, just really depending on what motion we can allow. And we also stabilize it. We can treat even difficult problems like a mid-carpal instability by utilizing a push pad, taking a volar to dorso approach, pulling up the carpus. Because these people who have that true clunking, if we put them in a static orthotic and we expect them to want to go golf, they can't. And a lot of my patients were frustrated, and I thought, well, how can we control enough motion where they're not getting that true clunking, okay, true non-dissociative mid-carpal instability? You'll get a clunk, the end, the proximal end. So we can use an external device to help treat these patients, because not all of them are going to be surgical candidates. Is that right, Dr. Badea? So the way I do it in therapy is I look at how much motion, I analyze how much motion can they do without clunking, and then I just grade it from there. So I could give them 30 degrees extension, 20 degrees flexion, maybe block ulnar radial deviation, start strengthening the carpus, and then, again, allow that motion on their own. So we want to wing them out. But we also want to protect them. So they're going to go back to the splint because they're going to need protection out there. Once you've compromised the wrist, you always have a compromise, right? The integrity's gone. So this is another approach to treating these people through the full spectrum of care. That's it. Thank you.
I think it's time to hear from somebody who can give us a perspective from an athlete, not just an athlete, but an Olympian, somebody at the elite level, and what sort of this can mean for him. Maybe we should give him one of these. Maddie, what?
My name is I'm Manny Huerta. I'm one of the two men that went to the 2012 Olympic Games for triathlon. And I want to thank Eric and Dr. Padilla here for inviting me and being part now of the Ortho Now. I wanted to give you guys a couple of tips. You don't have to be a professional triathlete or an Olympian. You can be just the weekend warrior runner. But as a triathlete, as an endurance athlete, we put our body through a lot with the swimming, with the biking, with the running, and sometimes we think more training it's better, and we never schedule or listen to our recovery part of the training, and I think it's very important. It's as important as the training itself. So a few little things we can do to make our training better and so that we don't get hurt or we can train faster. The few little things I do, for example, when I do a track session, the runnings the run part out of the three sport is the toughest one on your body. It has the most pounding. It gets you more tired. So what I think the best thing to do after a hard running session is actually to go in the afternoon and do a little spin bike session or a little swim, something that relaxes you a little bit, something that gets your blood going again, so that the following day you don't feel like you have this 2,000 pounds legs and you're trying to go run. The other thing is, I know that you guys, you're doing some training and you then you have to go work. There's a lot of protein shakes. There's a lot of you can make your own smoothies. There's a lot of recovery drinks, and sometimes between your running session and going back home or going to work, it takes a long time because you're driving. I would like for you to do the same thing I do. Is actually I already make my recovery stuff before I go to the running or to the bike or to the swim session or to the gym, and I have it with me in the car. I have a small cooler, so when I finish the workout and I go home or I go to work, I already start getting some fluids. I already start getting some nutrition that can help me out with the recovery part. Here in South Florida, it's very hot. It's very humid, so we sweat a lot. So having some like the nutritionist we had, getting some fluids, but also having some fruits too is good, so that we can get home, or we can get to work with something in our stomach. When you're working and you're standing up the whole day, or you're sitting down, maybe wearing some compression socks will help you a lot for like the inflammation and the recovery part. At home, what I do at night is, after a long day of 4 or 5 hours of training, I actually sleep with my compression socks on, and then the following day, I take them off to go work. Another thing that I like to do is during the weekends, we usually put the most amount of training, just because that's when we have the time off. If you can get to a 7-Eleven or to a gas station and maybe buy 1 or 2 ice bags, and then you go home and then you fill up your tub a little bit, you put the ice on, and you get like your personal ice bath machine there. So you sit there for 10-15 minutes. That will help you with your recovery. What I do, I have like a mini pool that I have on the backyard, one of those that you just inflate for little kids, and I fill it up with water, and I put the 2 bags in, and I sit there for a little bit. It's actually, it hurts a lot to sit there, but it will help you a lot. And one of the best things, and I know not many of us have enough time during the day to do this, but I think the best recovery thing that you could do is actually take a nap. When we're very tired, and if I feel that when I take that 30 to 40 minute nap, that will get me like ready for the afternoon session, or for the afternoon meeting, or for the afternoon anything you have. So I wanted to keep it short because we've been very late, but I want you to think about your recovery before you actually do the workout, so that when you work out, don't start thinking and start prolonging it. So that way it comes automatic, and you have it ready, and you can get yourself not healthy, but recover fast enough for the following day or for that afternoon workout. Thank you for having me here. If you have any questions about any other thing afterwards, feel free to ask me.
You want him to? Do it? How do you want it? How do you want to do that, Eric? Do you have a?
All right.
So we're just gonna get the lucky. Okay. Dun, 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 dun. And the Oscar goes to Armando Perez.
You have to ride home, though. That's a trick.
Yes, that's right.
Yeah, he might get there quickly.
Here's what you get. Unbelievable. That's my bike?
That's your
Your
bike.
bike?
Wow.
Congratulations.
When's the next Olympics?
Sure.
Let's do that next. We have one more giveaway.
Enjoy, man.
Yeah.
Yeah.
You gotta get it home, right? I'm sure the folks at the Park Center would let you keep it overnight.
Give me my card.
So,
All right, now we're going to give away
matters.
Put it up here.
from the 2012 London Olympics.
Wow.
Well, this is the uniform I wore at the Pan American Games, and I won the silver medal in 2011. This was one of the best races of my career. It was down in Mexico. So I wanted to come here and bring something so that I haven't signed it yet, so that the winner can get their name. I have the Sharpie and everything. So let's see who gets the uniform. Pete Rodriguez. Where's Pete?
I guess maybe on the.
Yeah, you don't have to be present. So.
Okay, all right.
I sometimes use a name, Pete Rodriguez. That's wonderful. So.
That's very exciting.
So people could do this online through Fit Triathlete. They could have entered. So yeah. Hopefully a lot of people did, and this really means a lot for Special Olympics. So it's very, very generous and thoughtful, because somebody athletes will be able to go compete because of funding. So,
okay.
Thank you.
Thanks, man.
So there wasn't much time for questions. Obviously, some people will be milling around, but if there's any burning questions for anybody, the participants, now's the time. Remember, through the website, you'd be able to ask any questions anyway. That's something we want to be accessible. So really, thanks to all of you for making the first year of the annual event a success. Yeah, John, thank you.
Yes, I'd like to thank Dr. Padilla, team of Ortho Now, as well as the team at the Mark Center to help us with the tech part of this thing. It wasn't easy, and thank you to Eric Rylander, who put a lot of work into this, and thank you to the panel, Dennis, Linda, Amanda, and Larry, that came to us from San Francisco, Arizona, and Mississippi. The true power of this new Hangout technology. So thank you. I guess we're off the air. Can you guys hear me? Larry, can you hear me?
I can hear you.
Yeah, okay, man.
I unmuted.
I guess,
can hear you, John.
Thank you very much for coming.
Oh, you're very welcome, John.
Yeah,
Amanda.
I think that went very well. That was a complete little seminar.
Yeah.
I hope the people in the audience there in person liked it. It's always hard to combine in person with people from afar.
Yeah. Well, technically it was okay. Not too bad. Not any huge glitches. But
that's good, John. I think that, and Amanda might agree, I think that there's a lot of opportunity for getting together people, like Amanda sitting in her room there and me sitting in my room here, to talk to people about things where it isn't possible to travel and do it in person. And John, I think you really do have the right idea
Well, Larry, I always remember what you said to me about how when you go to a conference, you just really go for a couple of talks, and the rest of the time,
Right.
and you pay huge amounts of money to travel and a hotel.
Right.
And really, what you're after is the mind of those presenters, and you can get the mind from a hangout. Really, you don't have to go to
I
Dubai.
think that's right, John. And it's one thing when we're doing that for business purposes, and we're going off to a meeting, and there's a social part of that to networking, and it all has a professional sort of side to it. But there are when it's not part of your business or your work, and you're a triathlete sitting at home, there's no. It's really a big expense and a big deal to say pick up and go to somewhere to listen to some experts talk about some things.
Yeah.
And it just seems like in 2015, with the technology that's available, it ought to be possible to get people together to have conversations that are helpful.
Well, we just, I think I told you, we just did the conference from Spain on neurointerventional radiology.
Yeah.
2 day, and it went well. So now, we can monetize that. The next one we're going to, charge, obviously.
Sure.
We had to show them we could do it first.
Right.
And the beautiful thing about it, Laurie, was it was mobile. It brought all our own stuff. We didn't need to tap into the system of the center or the hospital,
right.
which is really really great. And we're going to try it. For some reason, we're moving faster in Spain than here for some reason. But certainly, Larry, if you're welcome. If you need to do hangouts with anybody, if you're interested in doing talks on health and triathlons, whatever, you're always welcome to shoot me an email and say you want to do it.
Maybe we'll do that sometime, John. I think that might be fun.
Yeah. Okay. Great. And
Very good. Again, thanks for the invite, John.
Okay. Thank you. Okay. Good night.
Bye-bye.
Okay, Linda.
Good night.
Okay, Linda. Thank you. Did you get everything? Did you get everything out of that, Linda?
Yeah, I did. That was really great. It was really interesting to hear everybody speak and hear such a variety of different people. Hear a cardiologist speak and an orthopedist speak from different specialties, and yeah, that was great.
Yeah. Well, this is the new face of conferences. There'll be in person and hangout, because look at what it did. It brought you from San Francisco to Miami. It brought Larry from Mississippi. It brought Amanda from Arizona. I mean, you guys didn't have to travel, but yet you took part in the conference. So
yeah,
that's one of
the
one of the advantages of technology. It allows us to do that, which is I think you're going to see this part what we did hang up. I think it's going to see it grow and become more of an integral part of conferences for people they can't get, or they're too busy, or in Japan or far away, because you would be amazed. You can make connections with people in Saudi Arabia, and the picture is just as good as my picture, and the sound, it's like they're next door. I mean, it doesn't matter where they are in the world, as long as they have a broadband connection and a good webcam, it's like next door. So you're gonna see part of it. Yeah, but let me know if you want to do a review of your app. Just you got my email address, right?
Yeah, I'd love to. I'll send you an email. Maybe in a couple of weeks. That would be great to do that. And
send me an email. We'll do it. We'll bang it out in a half hour.
Perfect.
Okay.
Perfect.
Nice meeting you, Linda.
All right.
Bye-bye.
Nice to meet you too. Bye.